If somebody's ever told you that your blood pressure is too high, then there is a very good chance that the first thing they said was to cut back on your salt, maybe to stop eating crisps or chips, to stop adding so much salt to your food. Maybe you were handed a leaflet, maybe you were told to come back in 6 months. And I want to be fair here, that advice isn't entirely wrong. Salt obviously does play a role, but the way it dominates the conversation, the way it becomes the headline every single time blood pressure comes up, has caused enormous harm. Not because the advice is dangerous, but because it shifts the attention away from the things that matter far more, and it leaves millions of people doing the right thing on paper and still not getting any better, and they're just wondering what on earth they're doing wrong. And I've sat with those sorts of patients. I've spent nearly a decade working in emergency medicine in the NHS, and I've seen people coming back again and again with their blood pressure still too high, with more medication added, and then your blood pressure is still too high. Salt has been addressed, exercise has been included in their routine, and yet the number on the cuff barely moves. And rather than questioning the framework, the assumption is always that the patient mustn't be following the advice properly, that the patient is doing something wrong, that they must be cheating and not telling you everything. And that assumption is wrong. So what I want to do in this video is actually explain what's driving blood pressure in most people, not all, but in the vast majority of cases. Not the traditional textbook version, but the fuller picture, the one that includes how your hormonal system, your nervous system, your kidneys, and your food environment all interact. Because when you see the entire picture, and this will be a long video, it will make a lot more sense if you follow it through to the end. If you're new here, then hello, my name is Alex. I'm an emergency medicine doctor in the NHS. I've been working for around 10 years now. And what I do these days is focus a lot more on lifestyle medicine, essentially asking the question of why some people get sick in the first place, rather than just managing what's already gone wrong, basically trying to prevent the end-stage disease that I see every single day. And blood pressure is genuinely one of the most instructive topics here, because almost every modern chronic disease that we see eventually shows up in what's happening to your blood vessels. So here's the plan for this video today, because there is a lot of groundwork to cover and I want you to know where we're going to end up going. So we're going to start with what blood pressure actually is, the two numbers, systolic and diastolic, what they mean, why they matter, and then we're going to go into the three systems that control blood pressure, because that's the framework that everything else hangs on. From there, we're going to talk really honestly about salt, about what the evidence actually shows, where it's really relevant, but also where it's not relevant. And then we're going to get into the thing that almost nobody brings up when they talk about blood pressure, and certainly most GPs will not talk about this, and that is insulin. Chronically elevated insulin is, in my view, the dominant driver of high blood pressure in modern populations, and I'm going to walk you through the exact mechanisms, 3 of them, because once you see it, you can't really unsee it. And if you have high blood pressure, this is what you need to know. After that, we'll talk about ultra-processed food, not just as a salt vehicle, but as something that deploys multiple blood pressure raising mechanisms simultaneously, while stripping out the things that would otherwise protect you. Then we're going to cover what actually works, things like exercise and sleep, potassium, meal timing, with the specific mechanism behind each one. Not just, this is the thing that's good for you, so do it. We'll actually go into each one in detail. And then we'll finish with medications, what they do, what they don't do, and why that distinction matters, even if your numbers are currently controlled. So what I'm hoping is by the end of this really long video, much longer than my average one, you'll have a framework that is genuinely more complete than what most people will get from their doctor. I'm really, really hoping that this will answer a lot of questions that a lot of people have. So the first thing to talk about is what blood pressure actually is and why it even matters in the first place. So blood pressure is the force that your blood exerts against the walls of your arteries as your heart pumps it around your body. That is the very basic definition. The number that you get when somebody wraps a cuff around your arm, something like 130/80, gives you two pieces of information. The top number, systolic, is the pressure when your heart is actively contracting and pushing blood out away from your heart. The bottom number, which is your diastolic pressure, is the pressure in your arteries between beats when your heart is filling back up and relaxing essentially. Both of those numbers matter, and it's worth saying that diastolic pressure, which is the bottom number, tends to get less attention than it deserves, particularly in younger people where isolated diastolic hypertension is actually more common than most people realise. Now, normal is considered below 120/80. Most people tend to know that. High blood pressure or hypertension is consistently above 130/80, though guidelines do vary depending on where you are in the world. Now, severe hypertension, the kind that brings people into the emergency department with headaches or visual disturbances, and occasionally something far worse like a stroke, tends to be above 180, although clearly that is not always the case. The vast majority of people with hypertension are in that moderate zone, in that middle ground. Not dangerously high on any given day, but high enough that over years and decades, it wears things down and it's dangerous. And that is really the key word here. It is wear and tear. High blood pressure doesn't usually announce itself dramatically. It just quietly, relentlessly damages your blood vessels throughout your body, like the small vessels in your kidneys, the arteries supplying your heart, the vessels in your brain, the eyes, and also the erectile tissue in men. And I did a video on this a couple of months ago. It accelerates the process of arterial aging. It makes your vessels stiffer and less responsive and more prone to plaques and clots that I'm sure you've heard about in the context of heart attacks and strokes. This damage accumulates silently for years before it suddenly isn't silent anymore. And what it becomes at that point, again, can be a heart attack or a stroke or kidney failure or sudden blindness in the eye. This is why blood pressure matters so much. It's not that any single high reading is a crisis, it's that a sustained high reading, even just a little bit, is a slow process of systemic damage that you won't feel until a great deal of damage has already been done. And there's one more thing worth saying at this point before we get into the mechanisms, which is that high blood pressure is not a single number with a single cause that you can trace back to one decision that you made. It is a dynamic measurement that fluctuates throughout the day, every day. It rises when you're stressed or you're active, and then it falls during sleep. Well, that's what it should do anyway. And it also varies with posture, with breathing, with hydration. White coat hypertension or white coat syndrome, where readings are elevated in a clinical setting due to anxiety, but they're normal elsewhere, and this is, incredibly common. This is real, and it's worth knowing about, which is why home monitoring or 24-hour ambulatory monitoring often gives a far more accurate picture than a single reading taken in your GP surgery. What the cuff gives you is a snapshot. It's a bit like the CTG when you're pregnant. It gives you a snapshot of that moment in time. And behind that snapshot is an enormously complex set of systems that are constantly negotiating with each other all the time. And once you understand that complexity, the idea that just adding a bit less salt onto your food is going to dramatically alter what's happening to your blood pressure becomes a lot harder to sustain. Right then, so your blood pressure is controlled fundamentally by three things working together. You've got a volume, which is how much fluid is in your bloodstream. You've got resistance, so how open or constricted your blood vessels are. And then you've got cardiac output, how hard and fast your heart is actually working. So you've got volume, resistance, and then cardiac output. If you change any one of those three things, then your blood pressure will change. But each of those three is itself under constant hormonal and neurological control, which means the real question isn't which of those three is out of balance, it's what's regulating them and why the regulation has gone wrong. The first system is your kidneys, and the kidneys are, in many ways, the unsung heroes of blood pressure regulation. Their core function, among many, is to maintain the right amount of fluid in your bloodstream. They do this by constantly filtering your blood 24/7 and then making real-time decisions about what to keep in and what to excrete in the urine. More fluid in the blood means more volume pressing against the artery walls, which means higher pressure. Less fluid means lower pressure, and to most people that'll be fairly obvious. Now, the kidneys don't do this randomly. They are responding to hormonal signals every second of every day. When your pressure drops too low, a cascade kicks in. Your kidneys release an enzyme called renin, R-E-N-I-N, renin. And renin converts a protein in your blood into something called angiotensin 1. That then gets converted into angiotensin 2, which is a hormone with significant power. Angiotensin 2 does two things that raise your blood pressure. It tells your vessels to constrict, which increases resistance, and then it signals to your adrenal glands, which sit on top of your kidneys, to release a hormone called aldosterone. Now, aldosterone tells your kidneys to retain sodium, and where sodium goes, water follows. More water retained means more blood volume, which means more pressure. This whole cascade, so renin, angiotensin, aldosterone, is what we call the RAAS system, R-A-A-S, renin, angiotensin, aldosterone system. And it's the mechanism that a lot of blood pressure medications actually target. So ACE inhibitors like ramipril or lisinopril, they block the conversion of angiotensin 1 to angiotensin 2. ARBs, angiotensin receptor blockers, block angiotensin 2 from binding to its receptor. So they are both very effective drugs for this exact reason. Anyway, the point about your kidneys is this. They are not just like a paper filter that just filter things in and out. They are active participants in blood pressure control. They respond to signals from your hormones, your nervous system, and the composition of what's in your blood. And when those signals are persistently telling your kidneys to hold on to more fluid than they should, well, you end up with a blood volume that's chronically elevated and a blood pressure to match that. The second system is your blood vessels themselves, specifically the artery walls. So think of your arteries like rubber tubing rather than rigid pipes. When pressure rises, healthy arteries stretch slightly to accommodate it, and then they recoil. And this elasticity acts like a buffer. It smooths out those big peaks of pressure, and it reduces the strain on the downstream vessels and organs, protecting things like your kidneys and your brain from those big pressure spikes. Stiff arteries can't do this. Stiff arteries transmit pressure directly, amplifying it downstream rather than absorbing it. Now, inside every single blood vessel in your body, there is a single layer of cells lining the inner wall called the endothelium, one of the most important tissues in the body. And it's one that I talk about all the time in my videos, but most people have never heard of it. Now, the endothelium isn't just passive tubing, it is metabolically active tissue. It is constantly sensing the blood that flows over it, reading the shear stress, SHEAR stress, sensing chemical signals, and adjusting its behavior in response. Now, the most important thing that the endothelium produces is actually a molecule called nitric oxide, which is a gas. It's a short-lived, locally acting signaling molecule that diffuses into the muscle layer of the artery wall and causes it to relax. And relaxed muscle means a wider vessel. Now, wider vessels obviously mean lower resistance. Lower resistance means lower pressure. And healthy endothelium producing good amounts of nitric oxide is one of the most powerful blood pressure regulating mechanisms that you have. And when the endothelium is damaged by things like inflammation or oxidative stress or chronically elevated glucose or insulin, it produces less nitric oxide. Your vessels become stiffer, less able to relax, and the resistance increases, and your blood pressure stays elevated. And crucially, this is not a reversible process overnight. Years of endothelial damage accumulate, and this is why hypertension that's been present for a long time becomes harder to treat. It's not impossible, absolutely not, but it just becomes harder. The structural changes in the vessel wall have become almost self-perpetuating. Now, the third mechanism is actually your nervous system, specifically the autonomic nervous system, which controls things that you don't consciously manage, like your heart rate, your vessel tone, your breathing. Your autonomic nervous system has two branches that broadly oppose each other. The sympathetic branch, so fight or flight, speeds things up, constricts your blood vessels, raises your heart rate, but also your parasympathetic branch, so your rest and digest system, and that does the opposite. For blood pressure, the sympathetic branch is the one that matters the most. When it's activated, your heart beats faster and faster, and your blood vessels constrict. And in the short term, that is appropriate. It's designed for genuine emergencies. But the problem arises when that system is running at a chronically elevated baseline, when your sympathetic tone never really switches off, when even at rest, your nervous system is quietly telling your heart to work harder and your blood vessels to stay narrowed. And this is why chronic stress raises your blood pressure. This is why poor sleep raises your blood pressure. This is why people who are constantly over-caffeinated and under-rested often have elevated readings. The sympathetic nervous system never gets to stand down. So your blood pressure comes down to three things. You've got volume, which is how much fluid is in your bloodstream. You've got resistance, how tight your blood vessels are. And then you've got cardiac output, how hard and fast your heart is working. But those three aren't acting on their own. They're being constantly controlled by deeper systems like your kidneys, your blood vessels themselves, and then also your nervous system. And if you're wondering whether there's a single input that can influence all three at the same time, then yes, there is, and I'll get onto that in a short while. At this point, let's just be really honest about sodium. So sodium, which is the relevant component in salt, does have a well understood mechanism for raising your blood pressure. Sodium is what we call osmotically active, which is the technical way of saying that it pulls water towards it. So when sodium concentration in your blood rises, your body responds by retaining more water to dilute it, which increases your blood volume, which increases your blood pressure. Now, the DASH trial, DASH, which is one of the most important dietary intervention trials in blood pressure research, showed that sodium reduction can lower your blood pressure by a good amount in certain populations. The InterSalt study, which looked at thousands of people across lots of different countries, found a correlation between population-level salt intake and blood pressure. Now, these are real findings. We can't dismiss that sodium has an impact on your blood pressure. Salt matters, but here's what the nuance looks like in practice, and this is where it gets really interesting. So salt sensitivity, which is the degree to which a person's blood pressure rises in response to salt intake, varies enormously between individuals. And in some people, sodium reduction produces dramatic improvements. In others, it does almost nothing measurable, and I am one of those people. And the factors that predict how sensitive you are tell you a lot. So people with CKD, chronic kidney disease, are very highly salt sensitive because their kidneys have lost the capacity to effectively excrete sodium. So excess dietary sodium accumulates. Older adults tend to be more salt sensitive as well for similar reasons. Their kidney function just naturally declines with age. And the system's ability to self-correct is obviously reduced as well. Now, there are also well-established ethnic differences. So people of Black African heritage, on average, tend to show higher salt sensitivity as well, thought to be related to evolutionary adaptations to hot climates. In these populations, sodium reduction is particularly meaningful and should absolutely be emphasized. But in a substantial proportion of people with hypertension, particularly younger people without significant kidney dysfunction, salt sensitivity is modest. The kidneys in a healthy functioning system are actually very good at handling moderate dietary sodium variation. They're designed to. The body has redundant mechanisms specifically to manage this. It's also worth addressing the other side of the argument because some researchers have actually suggested that a very low sodium intake might actually increase your cardiovascular risk through the activation of the RAAS system, again, RAAS, and compensatory rises in other hormones. The evidence on that is really contested, and I don't really want to overstate it, but it does suggest that the relationship between sodium and cardiovascular outcomes is probably J-shaped rather than linear, meaning that extremely low intake isn't necessarily the goal. As with everything, context matters enormously. So why then does blood pressure stay elevated in so many people even when salt is reduced? And that really is the big question of this video. Well, the answer is something else is overriding the normal regulatory mechanisms. Something else is locking the system in a high pressure state. And that's something in the majority of people in modern Western populations is insulin. So insulin is a hormone that most people connect exclusively to blood sugar and diabetes. It's released by your pancreas in response to rising blood sugar, and its primary job is to signal cells, especially muscle and liver cells, to take up glucose from the blood and use it for energy or store it. When insulin works properly, your blood sugar rises after a meal and then comes back down. Nice and simple, and this is what's supposed to happen. But insulin is not a one-trick hormone. It has receptors throughout the body, including your kidneys, your blood vessel walls, and your nervous system. And when insulin levels are chronically elevated, not just spiking appropriately in response to a meal and then returning to baseline, but persistently elevated throughout the day, the effects in those tissues become significant. So let me walk you through exactly what happens, because this is where it gets really important. So effect number one is on the kidneys. Now, insulin, acting on the kidney tubules themselves, promotes sodium retention. And this is a direct effect, not mediated by aldosterone, not mediated by the RAAS cascade, which we just talked about. Insulin itself tells the kidneys to hold on to sodium. And you're probably thinking, but why would insulin do that? Well, there is an evolutionary logic here. In ancestral environments, periods of eating were also periods of physical activity and muscle use, during which sodium conversion might be useful. The problem is that we've massively overloaded this system by maintaining high insulin levels for extended periods of time without the physical demand that was supposed to accompany them. So what chronic hyperinsulinemia, chronically elevated insulin, produces in the kidneys is persistent sodium retention. Not because you've eaten more salt, but because your hormonal environment is telling your kidneys to hold on to whatever salt is there. Now, you can see why reducing dietary salt in this context has a very limited effect. You've reduced the input, but the instruction to retain is still running. The signal hasn't changed. Now, effect number two is the sympathetic nervous system. This one surprises a lot of people, and I touched on it a few minutes ago. So elevated insulin directly stimulates the sympathetic nervous system. It increases the firing rate of sympathetic nerves supplying the heart and the blood vessels. What that means practically is that chronically elevated insulin, which means elevated insulin for prolonged periods of time, keeps your sympathetic tone chronically elevated as well, keeping your heart rate higher than it should be at rest, keeping your blood vessels more constricted than they should be. It's like having a fight or flight response on a very low simmer, constantly in the background. And there's really good experimental evidence for this. So studies have actually infused insulin directly into people's bloodstreams, and it's shown measurable increases in sympathetic nerve activity within minutes. So this isn't just theoretical, it's been directly measured. Effect number three is all about the endothelium again. So chronic elevation of insulin, and even more so the chronic elevation of blood sugar that normally accompanies it, produces what's called oxidative stress in the vessel wall. Now you can think of oxidative stress almost like a kind of biochemical rusting. Free radicals accumulating in the tissue, damaging cellular structures, impairing their function. And one of the first casualties is nitric oxide production in that endothelium, which we just talked about. Damaged endothelial cells produce less nitric oxide. Less nitric oxide means less vascular relaxation. Vessels become stiffer, resistance rises, and this damage, once it's been happening for years, is not quickly undone. So high levels of insulin over prolonged periods simultaneously tells your kidneys to retain sodium. It activates your sympathetic nervous system to constrict your vessels and raise your heart rate. And it also damages your endothelium, so it can no longer produce the molecule that would otherwise cause your vessels to relax. Three mechanisms, three simultaneous pressure-raising effects, all from one hormonal signal, insulin. And then we can ask ourselves, well, what drives chronically elevated insulin in modern populations? The answer overwhelmingly is diet and eating patterns, specifically a diet high in rapidly digestible carbohydrates and refined flour and sugar and ultra-processed foods, combined with eating constantly throughout the day. None of us are ever hungry anymore. There is food literally everywhere. Every time you eat carbohydrates, your blood glucose rises, insulin is released, and if that cycle happens every 2 hours from morning to night, insulin never really has time to return to baseline between meals. Your pancreas is constantly producing it. Your blood levels stay elevated, and all three of those downstream effects stay running. Now, we've got to be really careful here because somebody will rightly point out that not everybody with high insulin has high blood pressure, and not everybody with high blood pressure has high insulin. Both of those things are true. Hypertension is not a single disease. It is a final common pathway reached by multiple different routes. And in some people, particularly older people, structural changes in the arteries from aging dominate the picture regardless of metabolic factors. But in the majority of modern Western populations, particularly those in middle age carrying extra weight, eating processed food, or not sleeping well, insulin resistance and hyperinsulinemia are central to what is happening. This is not a niche hypothesis. The connection between insulin resistance and hypertension is well established in the literature. Now, the metabolic syndrome, which is a cluster of conditions including high blood pressure, high blood sugar, high triglycerides, low HDL cholesterol, and abdominal obesity, this is defined by insulin resistance. People with type 2 diabetes, which is characterized by extreme insulin resistance and often high circulating insulin, have hypertension at dramatically higher rates than the general population. Now, this isn't just coincidence. This is the same mechanism, just further along the spectrum. When we talk about lifestyle factors for blood pressure, we tend to list them individually, like salt, alcohol, exercise, stress, sleep, weight, and clinically, they're often addressed individually as well. Here's a leaflet from your doctor about salt. Here's a referral to the gym. Here's something to manage your sleep as well. But that approach absolutely misses the point because most of these factors converge on the same underlying pathway. Most of them ultimately end up affecting insulin or endothelial function or your sympathetic tone. They are not 7 separate levers, they are 7 different ways of affecting the same core system. Now, alcohol is a very good example of this because it often gets just a cursory mention in blood pressure conversations without much explanation. And there are actually lots of different mechanisms going on at the same time here. You've got acute alcohol raising your sympathetic nervous system activity. You've got regular drinking impairing how insulin works and contributing to weight gain around the abdomen. And it also disrupts how well you sleep as well, which, as we'll get onto in a minute, matters enormously for your blood pressure. It's not just that alcohol is generally unhealthy, it is hitting the same 3 systems we've just been talking about. And understanding that makes the conversation about what to actually prioritize much clearer. You're not just managing a list of things here, you are managing an entire system. And that is the reframe that I want you to have here. Now would be a really good point to talk about ultra-processed food. So ultra-processed food is defined by how it's made rather than just what it contains. So industrially produced using ingredients and processes that you wouldn't find in a home kitchen, with extensive use of additives and emulsifiers and flavor enhancers and modified forms of fat and oils and starch and protein. Technically, the NOVA classification describes it, N-O-V-A, so you can search for that on Google and read a bit more about it if you want. Practically, It is most of what's in the middle aisles of a supermarket. The blood pressure problem with ultra-processed food isn't simply that it contains salt, although often it does and in large quantities. The problem is the package deal. A typical ultra-processed meal or snack, which all of us have eaten, I'm sure, delivers lots of refined carbs really fast, which absorb and spike your glucose really quickly. The fibre essentially has been removed, and fibre is what would normally slow glucose absorption in a whole food. So you get a faster, higher blood sugar spike, which demands a larger, faster insulin response, and that's really important. Simultaneously, the meal often contains significant sodium, so you're adding to fluid volume at exactly the moment your insulin is telling your kidneys to retain it. And the food is almost universally depleted in potassium because potassium is found in the cell structures of whole foods, and food processing destroys those structures. And potassium matters enormously here, and it gets almost no attention in the standard conversation. How many people have ever told you to watch how much potassium you're eating? Barely nobody. Potassium is the physiological counterbalance to sodium. In the kidney, potassium and sodium are in direct competition. When you excrete more potassium, you tend to retain more sodium, and then vice versa. Potassium also has direct effects on blood vessel smooth muscle, helping your vessels to relax. And high dietary potassium has been shown repeatedly in well-designed trials to lower your blood pressure significantly. The DASH diet, which is always cited in these sorts of conversations, and it's one I often refer to in my videos, is often credited for its sodium reduction, but the effect size in the trials is at least as much explained by its dramatic increase in potassium from fruits and veg and legumes. Whole foods, particularly veg and beans and lentils and nuts and fruits, are naturally rich in potassium. Ultra-processed food strips all of that out. So when you switch somebody from a whole food diet to a heavily processed one, you're not just adding salt, you are removing potassium. You're shifting the balance in the kidney in the worst possible direction simultaneously. Now, if you add to this the fact that ultra-processed food is engineered to override satiety signals, it's designed in many cases explicitly to produce overconsumption, this means people eating heavily processed diets tend to eat more frequently, to snack more, to have that insulin cycle running more continuously than people eating whole foods. The meal pattern problem layers on top of the food quality problem. And then you've got weight. So excess body weight or body fat, particularly visceral fat, which is the type that's stored inside your abdominal cavity around your organs, is metabolically active tissue. It releases inflammatory signals. It releases free fatty acids that interfere with insulin signaling in the liver. It directly contributes to insulin resistance. So a person carrying significant visceral fat is in a state of low-grade chronic inflammation that drives insulin resistance even on days when they don't really eat particularly badly, if that makes sense. And I see this constantly at work in emergency medicine. People who are carrying a lot of visceral fat, and you can identify these people even before any blood test by the pattern of fat distribution around the abdomen, almost universally have metabolic problems, either elevated blood pressure, dysregulated blood sugar, abnormal lipids on the blood test, early kidney disease. The fat isn't just cosmetic tissue. It is an organ producing hormonal signals that are driving disease. Now, this feels like a really good point to step back a bit because we've covered a lot of ground so far. We've started with the three systems that control blood pressure. So the kidneys managing volume, the blood vessels and their endothelium managing resistance, and the autonomic nervous system managing cardiac output and vessel tone. We established that salt affects one part of the system in some people and that the standard conversation misses everything else. Then we went into insulin, how it affects all three systems simultaneously when chronically elevated, and how chronic elevation is driven primarily by frequent eating of refined processed foods. We've looked at ultra-processed food specifically, not just as a salt vehicle, but as a package that deploys multiple pressure-raising mechanisms at once, while at the same time stripping out the things like potassium and fibre that would otherwise protect you. Now I want to talk about what actually fixes it. Not just avoiding the bad things, but the specific mechanisms by which the right interventions work. So let's talk about food quality and meal timing. The most powerful lever by far is reducing chronic insulin elevation over time. And there are two ways to do this that work really well together. The first one is food quality. So replacing refined carbohydrates and ultra-processed foods with whole foods automatically does several things at once. It slows glucose absorption through the natural fibre in whole foods. It dramatically increases potassium intake. It reduces the frequency and amplitude of the insulin spikes, and it tends to reduce caloric intake, calorie intake naturally, because whole foods are more satisfying per calorie. They fill you up a lot better. So what that means is that you do not need to calorie count. The food itself, in its unprocessed form, does the regulatory work for you. The second one is meal timing and frequency, and this is something that's becoming clearer in the research but still doesn't get enough attention in clinical practice. If insulin levels are chronically elevated because people are eating constantly, like every hour, then one of the most effective changes a person can make is to simply eat less often, to allow extended periods in the day where insulin falls to its true baseline. Now, this is not some extreme fasting or any particular protocol. It's about recognizing that the body has a natural rhythm throughout the day. Periods of feeding, periods of fasting, which is normal. And this is the rhythm that has important metabolic functions. When insulin is low for extended periods, the kidney tubules reduce sodium retention. Sympathetic activation from insulin reduces, and cells have time to restore insulin sensitivity. Your blood pressure comes down, not because anything was added, but because the persistent hormonal signal driving it up was given time to rest. In practice, I've had patients who have had big problems with their blood pressure for a long time, who have been resistant to other changes, but then who have had big reductions just by compressing their eating window and cutting out their evening snacks. Not dramatic changes in what they ate, just when and how frequent. Now, exercise is another big lever here. This is the second lever on the list today, and I want to explain exactly why, because it's not just exercise is good for you. The mechanism here is very specific and important. So physical activity, aerobic exercise in particular, is one of the most potent stimulators of endothelial nitric oxide production in your body. When blood flows faster through a vessel during exercise, the endothelial cells sense the increased shear stress, SHEAR, on their surface, and they respond by ramping up the production of the enzyme that makes nitric oxide, called ENOS, endothelial nitric oxide synthase. More nitric oxide means more vascular relaxation, lower resistance, lower blood pressure. What's particularly interesting here is that this effect is not just immediate. Regular exercise actually increases the baseline density of endothelial nitric oxide synthase. It physically remodels the endothelium to be more capable of producing nitric oxide at rest. This is why regular exercisers tend to have lower resting blood pressure, not because their heart is doing less work during exercise, but because their blood vessels have literally been trained to relax more. And crucially, this effect is independent of weight loss. Multiple studies have examined the blood pressure response to exercise programs in people who did not lose significant body weight and still found big reductions in blood pressure. The mechanism, again, is endothelial, not metabolic. You don't need to lose weight for exercise to lower your blood pressure through this pathway. Weight loss helps massively, yes, with the insulin pathway, but the nitric oxide pathway is running in parallel. Resistance training, so either lifting weights or just doing body weight exercises, has stronger blood pressure evidence than most people realize. And I mention this quite often in other videos. It was long assumed that aerobic exercise was the main prescription here. But more recent meta-analyses have actually shown that resistance training produces comparable reductions in blood pressure, possibly through a combination of improved insulin sensitivity, reduced sympathetic tone after training, and similar endothelial adaptations. The evidence for blood pressure now supports both, and ideally combining them during the week. There is also a dose-dependent relationship worth knowing about as well. So you don't need to exercise aggressively to get meaningful cardiovascular benefit. Studies consistently show that moderate intensity exercise like brisk walking or cycling or swimming performed for 150 minutes over a week, spread over most days, produces the large majority of the blood pressure benefit. 30 minutes most days is the prescription here, or ideally 10 minutes after everything you eat. Anything beyond that gives diminishing additional returns from a blood pressure perspective specifically, although clearly there are other benefits to exercise, so if you want to do more, then please do. Okay, let's talk about sleep now. So sleep is massively important, and I cannot overstate this enough. If you are serious about addressing your blood pressure, then you have to think about your sleep. So your autonomic nervous system, specifically the balance between sympathetic and parasympathetic tone, resets during your sleep. During the deeper stages of sleep, and particularly during slow wave sleep, sympathetic activity drops dramatically. And during this time, your blood pressure typically falls by 10 to 20% during sleep. So this is called the nocturnal dip, and it's considered healthy. This is what we want. It gives your heart and your vessels a genuine rest period every night. Now, people who sleep poorly, so fewer than 6 hours, or fragmented sleep, or sleep apnea, or shift work like many doctors and other healthcare people and firemen and police officers, they show blunted or absent nocturnal dips. The sympathetic nervous system is never fully standing down, and heart rate stays elevated minimally during this type of sleep as well. Your blood vessels stay constricted, and when this happens night after night, it accumulates. Chronic sleep deprivation has been shown in prospective studies to be an independent risk factor for hypertension, meaning it contributes to the development of high blood pressure over time, even when other factors are accounted for. Now, sleep apnea deserves its own mention here. Obstructive sleep apnea, where the airway repeatedly collapses during sleep, causes brief awakenings and oxygen desaturations. It's one of the most under-recognized causes of resistant hypertension. A patient whose blood pressure doesn't really respond to medication should always be asked about their sleep quality or snoring, or whether their partner notices them waking up at night and gasping, and also daytime fatigue as well. Sleep apnea treatment, typically with a CPAP device, CPAP, can produce really good reductions in blood pressure, sometimes allowing medication doses to be reduced or for them to come off medication entirely. It is a structural cause that needs a structural solution. And it's worth saying that sometimes losing weight has a big effect here as well. But beyond sleep apnea, there is simply the question of sleep quantity and quality. Poor sleep impairs insulin sensitivity. A single night of poor sleep measurably increases insulin resistance the following day. We know this from the research. Poor sleep elevates your cortisol, which raises your blood pressure through multiple different pathways. And what's also important is that bad sleep also drives your food choices the next day. And this is coming from somebody who used to work permanent night shifts for a long time. You are more likely to reach for processed, high carbohydrate foods when sleep deprived, partly because of hormonal changes in how your appetite works. All of this just loops round. Sleep affects how insulin works, which affects your blood pressure. Exercise improves your sleep quality. Food quality affects your sleep. These systems are not separate. They are just one interconnected system. And if you're addressing blood pressure by adjusting only one input while ignoring the others, then you're basically just working against yourself. Let me return back to potassium at this point. So potassium deserves more than just a brief mention. So let me give it the attention that it deserves. In most developed countries, average potassium intake is well below the recommended levels. The WHO recommends 3.5 grams per day. Most people eating a typical Western diet is getting considerably less than that. At the same time, sodium intake is often 2 to 3 times what we recommend as well. So you've got low potassium and high sodium, and that ratio has inverted completely from what our physiology evolved alongside. So for almost all of human history, the diet was very high in potassium coming from veg and fruit and legumes and nuts, and very low in sodium because there was almost no added salt and very little preserved food. The kidneys evolved in that context. They evolved to be very good at holding on to sodium, which was scarce at that point, and very efficient at excreting potassium, which was abundant. In our current food environment, where sodium is everywhere and potassium has been stripped from processed foods, those same efficient mechanisms work against us. The kidneys hold on to sodium very well, but there is very little potassium coming in to help push it out. Increasing dietary potassium through veg and legumes and avocados and bananas and sweet potato and nuts, most things good for us that are full of roughage, sits in this balance. More potassium promotes more sodium excretion in the kidney. And potassium has a direct relaxing effect on the vascular smooth muscle through its effect on cellular membrane potential. Essentially, more potassium makes your blood vessel walls less excitable and more likely to relax. The evidence for dietary potassium reducing blood pressure is strong and consistent, and I'll put a few links in the description below. But a 2013 meta-analysis from the BMJ reviewed dozens and dozens of trials and found that increased potassium intake reduced systolic blood pressure by an average of around 3.5 millimeters of mercury. And that might sound a bit modest, but population-wide, a 3.5 point reduction in systolic blood pressure is associated with a massive reduction in stroke risk and how many heart attacks we see. But just a point of caution here, if you have CKD or chronic kidney disease, then your kidneys may not be able to handle the amount of potassium that I'm talking about here. They may not be able to excrete potassium efficiently, and high potassium intake in certain people like this can actually be dangerous. So this is not universal advice. If you have kidney problems, or any other medical problem that means higher potassium intake could be dangerous, then you've got to make those changes with your doctor or actually discuss it with them first before making any changes. For everybody else eating a typical Western diet, increasing dietary potassium through whole plant foods is one of the most straightforward and underused tools available. And the effect doesn't require a supplement. It comes from food, from eating more plants, which is also delivering fiber and reducing your glucose spikes and reducing inflammation and improving insulin sensitivity. This is why whole food dietary patterns like the Mediterranean diet or the DASH diet or traditional Japanese diets consistently show blood pressure benefits. These patterns are addressing multiple mechanisms at the same time. And this leads me very nicely onto medication. Now, medication has saved an enormous number of lives and continues to do so. That goes without saying. When blood pressure is severely elevated, like over 180, well, reducing it fairly quickly, not too quickly, but fairly quickly is the priority. And medication is the right tool, and we prescribe it all the time. The risk of stroke and heart attack rises sharply at very high pressures, and waiting for lifestyle changes to work while somebody sits at 180 over 110 or 200, this isn't appropriate. For these sorts of patients, it's medication first and lifestyle alongside it. When blood pressure is moderately elevated and the person has coexisting conditions like diabetes or heart disease or kidney disease, the threshold for medication is always lower. And again, medication is appropriate. But there's a conversation that doesn't often happen, and that is about what the medication is doing and what it's not doing, and why the lifestyle question matters even when medication has normalized that number. ACE inhibitors and ARBs interrupt the RAAS cascade. They block angiotensin II's effect. They reduce sodium retention and vascular constriction. They work very well. They are very safe, and they have additional protective effects in the kidney. Calcium channel blockers like amlodipine relax the blood vessel's smooth muscle by interfering with the calcium signals that tell the muscles to contract. Beta blockers slow the heart rate and reduce cardiac output. They're less commonly used now as first line, but they remain really important in certain individuals. And my dad continues to take one, so people do still use them. Diuretics, or what we call water tablets in the UK, increase urine production and they reduce blood volume. They are effective and they're cheap, and they complement the other medications really well. All of these lower your blood pressure number really well, but none of them address the underlying root cause that drove the pressure up in the first place. A patient taking an ACE inhibitor like lisinopril, whose insulin remains chronically elevated, is still experiencing the three-system pressure from high insulin. The medication is pushing against that signal, but it's not removing it. This is why hypertension tends to be progressive, requiring more medications and higher doses in people who don't make any dietary and lifestyle change. The underlying driver is still active. These medications basically just put a plaster on it. They just partially counteract it. The goal in lifestyle medicine isn't just to get people off the medication just for the sake of it. It's to address the root cause so that the medication burden can be as low as possible, so that the downstream damage that blood pressure causes to your kidneys and your heart and your brain is minimized, not just through blood pressure control, but through the reduction of the underlying inflammation and metabolic dysfunction driving it. And as we get to the end of this video, I want to address one more thing before we finish, which is the psychological dimension. So blood pressure management is often framed purely as a compliance problem. So did you take your medication? Did you reduce your salt? Did you exercise enough today? And when the answer to those questions is technically yes, but the pressure remains elevated, the conversation can become frustrating and demoralizing. But what I found, and what the research on behavior change supports, is that people make sustainable changes when they understand the reason for them. Not you need to eat less salt because salt is bad for your blood pressure, but understanding the full mechanism, understanding why their food environment has been working against their biology, understanding the hunger they feel between meals, the difficulty concentrating, those energy crashes throughout the day, those are hormonal and they are related to the same underlying problem as your blood pressure. When somebody understands that eating more veg isn't just good in some vague general sense, but specifically increases the potassium that counteracts sodium retention, it increases the fiber that blunts glucose and insulin spikes, reduces the inflammation that damages the endothelium, the change has meaning now. It has internal logic, and changes with internal logic stick better than rules that feel arbitrary. Now, I also want to acknowledge that food environments are not equal. Whole foods cost more in most places. Time for cooking is not equally available. Ultra-processed food is generally cheaper and more convenient, and often more aggressively marketed in lower income areas. So telling somebody to eat more veg without acknowledging the structural reality of why they might not be doing it already is incomplete advice at best. But within those constraints, understanding the mechanisms still help. Even modest changes, small changes like eating more legumes, which are cheap and filling and potassium rich, choosing less processed options, for your evening meal, adding a walk after everything you eat, all of these produce real physiological effects. And knowing why they work is the thing that keeps people doing them when motivation inevitably fluctuates. So let's bring all of this together then. This is a really complex topic. Blood pressure is controlled by three systems: the kidneys managing volume, the blood vessels managing resistance, and the nervous system managing cardiac output and your vessel tone. Now, salt affects one part of one system in a subset of people. That's why salt reduction as a standalone intervention rarely moves the needle much in the majority of patients. The dominant driver of persistent elevated blood pressure in modern populations is chronic insulin elevation, driven by frequent eating of refined, ultra-processed foods. Chronically elevated insulin tells the kidneys to retain sodium. It activates the sympathetic nervous system to constrict vessels and raise your heart rate, and it damages the endothelium so it can no longer produce the nitric oxide that would relax those vessels. 3 simultaneous mechanisms from one hormonal signal. Now, ultra-processed food makes this whole thing worse through multiple different routes simultaneously. It spikes your glucose and insulin, it adds sodium, it strips potassium, it removes fiber, it overrides satiety, and it promotes continuous eating. It is not just a single ingredient problem, it is a massive food system and massive environmental problem. The most effective interventions work because they address the underlying hormonal environment. Whole foods reduce insulin spikes and restore potassium balance. Reducing meal frequency gives insulin time to fall. Exercise restores endothelial nitric oxide production independently of weight loss. Sleep allows the autonomic nervous system to reset and reduces insulin resistance. When these things work together, the body's regulatory systems start functioning as they should. The kidneys stop retaining unnecessarily, the vessels relax, the pressure comes down, not because it was forced down pharmacologically, but because the signal driving it up was removed. Now, medication is important. It is appropriate and essential in many patients, to be honest, but it addresses just the output, not the input. And understanding that changes what you do with the time between medical appointments. The number on the blood pressure monitor is not the story. It's the end of the story. And if you want to change the ending, if you want to reduce your risk of heart attack and stroke and literally live longer, then you've got to change what's happening earlier in that narrative. Blood pressure isn't just a seasoning problem. It is not the salt that you add to your food. It is a body-wide signaling problem. And the signal in most people has a name. It has a mechanism. And it responds to changes that are genuinely within reach. If you reached the end of this video today, then big hats off to you. You know, it was a long one. And let me know in the comments if longer videos like this are worth it, whether they are better than the shorter ones that I do. All of this feedback really, really helps me. And something else that helps me is if you like the video and subscribe to the channel. It helps so much to get these videos out to more people who could really benefit from them. And if there's something else you want me to focus on in the future, then again, leave a comment below. Have a great rest of the day, and I'll see you in the next one.